Good morning, everyone. And welcome to the Opioid Epidemic Crisis to Care and Medicaid Summit hosted by the Institute for Medicaid Innovation. Thank you for joining us today. The Institute is a nonprofit research organization focused on providing innovative solutions that address important clinical, research, and policy issues in Medicaid through multi-stakeholder engagement, objective research, data analysis, education, quality improvement initiatives, and dissemination and implementation activities. We are excited to bring together an exceptional group of national experts and leaders who will focus their remarks on opioid misuse during pregnancy and neonatal abstinence syndrome. We have clinicians, researchers, advocates, health plans, and most importantly, individuals enrolled in Medicaid who are impacted by the crisis. The summit would not be possible without the support of our partners and sponsor. I'd like to thank our partner organizations, the American Academy of Family Physicians, American Academy of Pediatrics, American College of Nurse Midwives, American College of Obstetricians and Gynecologists, March of Dimes, Medicaid Health Plans of America, and to our sponsor, Express Scripts. When asked why a summit focused on opioid misuse in the Medicaid population is important, our response is simple. This is not the problem of an individual. Opioid misuse is a social epidemic. Every age, from infant to elderly, has this threat in their life. It knows no boundaries, race, or gender. This can happen to anyone. It can happen to you, your family, colleagues at work. This isn't about good versus bad. This is about life, saving lives. Today's summit will focus on the science behind opioid misuse and the positive impact that our partner organizations are making on addressing this national epidemic. To kick off the summit, I'd like to introduce you to the moderator of the summit. Dr. Craig Martin is a national expert in the prevention and treatment of opioid use disorders, and with ongoing clinical and administrative experience in bringing about sustainable changes to population health. He is board certified in adult and child psychiatry, as well as addiction medicine, and currently serves as the chief medical officer for VIA Health. His organization's work in the Appalachia region has focused on addressing access to care issues for indigent as well as Medicaid members in Western North Carolina. Craig.
Well, thank you so much, Jennifer. I'm very appreciative of the opportunity to be here today with so many national experts. And we've been brought together by the Institute of Medication Innovations to share the good news about prevention, recovery, and treatment. We all know that social determinants and where we live, work, learn, play, and pray have a tremendous impact on health outcomes. We also know that mothers and babies have bright futures when we work collaboratively to provide needed treatment. This is both cost-effective and helps secure a bright future for all of us. Today I have the distinct pleasure of introducing to you our keynote speaker, Dr. Corey Waller. I will pass that on. Dr. Waller is the Senior Medical Director for Education and Policy at the Camden Coalition of Healthcare Providers and Chair of the Legislative Advocacy Committee at the American Society of Addiction Medicine. He has over a decade of experience working with patients who are pregnant and on controlled substances. And given his background in emergency medicine, he brings a unique clinical perspective. He's a recovery ally, a stigma buster, and a neurobiologist who uses data and science to inform his work and help in the education of our workforce. Please join me in welcoming Dr. Waller.
All right, so we have a short amount of time to make everybody here addiction specialists. In DC, everything gets compressed. Normally, things are 1 to 2 minutes, so I get 20, so that's like a millennia in time in DC. So I'm going to start off pretty quickly by one stating I have no disclosures. I get no money from pharma, no money from anything. I work for a nonprofit in Camden and get a salary, so that's what I do for a living, and the salary is equivalent to a nonprofit in Camden. So we'll just leave it at that. So In that role, my job is really to help us understand what are the gaps in education around addiction, pain, behavioral health, and even the system developments around those things. And one of the pieces that I have found that is very consistent throughout all of this is a lack of just knowledge about the disease of addiction. So I want to set this whole morning up by getting everybody on the same page about what is the disease of addiction, and then really what problem are we solving. So let's start with this. We need 3 things to survive, right? We need food, water, and dopamine, right? So dopamine is this chemical in the brain that is responsible for a mother-baby bond. It's responsible for creating a friendship. It's this chemical in the brain responsible for motivation in really any setting. So when I say dopamine, everybody should understand that I mean motivation. And when I say motivation, everybody should know that I mean dopamine. These are the same things. They are interchangeable, and they are fundamental to the basics of survival. And if you don't have dopamine that works properly, you don't actually have a reward system that motivates you to do the next best thing. So when you get up in the morning on Monday and you have to get your cup of coffee and you have to show up for work, that requires a baseline amount of dopamine. Now, interestingly enough, the National Institute on Drug Addiction has figured out what this baseline is. Dr. Elliot Gardner did some great studies that showed us that we actually need about 50 nanograms per deciliter of dopamine to get that cup of coffee. That's our morning when we wake up and we go to work. We know what this is, and it sits in this part of the brain called the nucleus accumbens. And I'm using these terms because every one of my patients knows these terms. They go to their primary care doctor and say, my nucleus accumbens isn't working right, so I'm just not quite feeling like taking that statin today. I mean, they know this, so we should know this. So the baseline is 50. So the worst day ever that we had, the day that you wake up and you fake vomit on the phone because you don't want to go to work and you're like, I can't come in, and you don't do anything, right? You lay there and you don't even get out of your pajamas and you sit around. And I have kids, so I'll sit around and play Xbox and basically say I'm sick and do nothing. That's 40 nanograms per deciliter, right? That's our low. That's what our physiologic low is supposed to be. What about our best day? Right, our best day ever, the day you immediately have 2% body fat, win the lottery, and own an island. All happens at the same time. That's about 100 nanograms per deciliter. So that's where we're supposed to live. Your favorite food has been found to be about 94 nanograms per deciliter, right? Sex, about 92. Yeah, bummer, maybe we need some more funding in that research, but I need to figure this out. But as we do this, we know that that's our physiologic norm. That's where we're supposed to live. That's what wakes us up. That's what makes us happy when we succeed. It's what drives us to do the next best thing. So what happens when we introduce something like methamphetamine into that equation? Well, you have something like methamphetamine and you take it, then all of a sudden that nucleus accumbens releases 1,100 nanograms per deciliter. Heroin about 950, alcohol in the 800s, tobacco in the 600s, marijuana in the 600s. All of these things that are considered addictive attack that very fundamental part of the brain that we need for reward. And when they do that, the body fights back. So that first time that somebody uses a drug that drives that dopamine to that level, it will never hit that again. In the layman's terms, we call that chasing the dragon. My patients will say, I was never able to get that same feeling again. And you know what? They weren't, because the body immediately corrected the amount of dopamine that it released. So when that happens, all of a sudden, if a patient continues to use, the body cranks down the production of dopamine, continues to crank it down. So it goes from 1,100 to 900 to 700 to 300 to 200 to 100, and then to 50. So if you're taking these drugs over and over again, the body has not only decreased the amount it releases, but the amount that it produces. Then, if you continue to use, it will actually atrophy the nerves so that they can no longer produce the amount of dopamine required. And if you consistently use after that, then what happens is the body kills that nerve because it feels like it doesn't need it. And then what we have is the equivalent of a stroke in the reward part of the brain. And a stroke in the reward part of the brain means you can't wake up and get that cup of coffee and go to work. You lose the capability to have motivation to do basic things like get out of bed and get dressed and go and follow up with an appointment or take a medication or go to therapy. So that lack of dopamine is an alarm bell for the system in the brain, and it knows that this is a problem because we require dopamine to go and get food and water. If you don't have it, you can't even get up to feed yourself or to go motivate to go to the sink and get a glass of water. So when that happens, we have a person who has craving. And what they're craving at that point is dopamine. And because the body craves dopamine to such a great degree, it will go to extraordinary lengths to obtain it through any means. And we've been able to compare some of these through these neuroscience studies where we look at what does it look like if somebody is starving? What does craving look like in the brain? We know the parts of the brain responsible for craving. We can see them on a functional MRI. We can see them light up when we show them the thing that they're craving for. So we've looked at patients who didn't get water for 3 days, so no fluid at all. So they're significantly dehydrated. We put them in a functional MRI. And by we, I mean the super smart, sciencey people that do this for a living, and I just interpret it, not that. So when they do this, and they put them in a functional MRI, and they play like waterfall sounds in the background. They sprinkle water on their feet. They let them taste water while they're in there to see how fundamentally like the drive is. What is the motivation to get water? What is the craving that the body has for that? And it's a relative size of about a baseball on this functional MRI. Then we look at food. They didn't eat for 5 days. And then they put them in a functional MRI, and then they have them talk about their favorite food. And then they bring it in and they like waft it into the MRI, right? So that you can smell it, but you can't eat it. They let them taste it and spit it out. And then they look at the functional MRI areas of craving, this area like prefrontal cortex and anterior lateral prefrontal cortex and then anterior cingulate gyrus. So we know the parts of the brain responsible for this. When we look at it, that's about the relative size of a basketball, right? So you're going to die of not being able to get water. That's about a baseball. You're not going to get food and you're craving food. That's about a basketball. We know what people will do when they're dying of dehydration or starvation. We see this happen all over the world in famines and that. You will rob your neighbor. You will kill another person who's starving in order to obtain food for that. I mean, imagine if I was walking through the desert for 3 days, I have no water, I get to the end of that, and there's this beautiful glass of water with condensation coming down on the sides, and it's like, I go to grab it, somebody steps in front and goes, no, that's not yours. I'd be like, okay, stab, and then I would move them over, and then I would take the glass of water, and I would drink it. And actually, as a society, we would start to be able to logic that out. Well, he was going to die, and they were going to keep him from getting the thing that was going to keep him from dying. But what do we do when somebody has craving for their dopamine, i.e. their drug of choice? It's not about the drug anymore. It's about the drive for dopamine. So when we looked at these patients, and we looked at patients who had been off of their substance of use for 30 days, 60 days, 90 days, 1 year, and 2 years, and I'm only going to talk about 30 days and 2 years, because there's no difference between a craving in a brain on 30 days, 60 days, 90 days, or 1 year off of their substance. It only starts to change craving when we get out to 18 months to 2 years. So we have the same fundamental platform for craving. So when we limit treatment for this, we have to know that we're not putting ourselves in a good position and definitely not the patient. So the craving for someone at 30 days was not a baseball, was not a basketball. It was a baseball field. It was 10 times the amount of craving. And when that happened, it actually shut off the signals to the prefrontal cortex, the part of the brain responsible for higher level thought and decision making. It shut off the signal to the hippocampus where we keep our memory. So it doesn't even allow us to look back on a memory of a bad thing that happened and use that to make our next decision. It is survival. And at that point, if we don't turn down that voice of I have to survive, then we will see the behaviors that we do. That's why they're predictable in this disease. That's why the DSM-5, the Diagnostic and Statistic Manual version 5, defines addiction not based on a lab test, not based on, a urine drug screen, not based on a one-time intervention, but what has the drug changed? 9 of the 11 things that create that diagnosis are behaviors. Only 2 are physiologic. And if you were prescribed opioids for pain, then those are even useless there because everybody on chronic opioids for pain has tolerance and withdrawal. So really the only things we have fundamentally left to diagnose addiction is behavior. And that behavior is how they connect with the medication and how it changes the way that they work within the rest of their lives. Will they choose the drug over family? Will they choose the drug over work? Will they choose the drug over the health care that they know that they need, but because the voice is so loud in their brain and not allowing them to look at these other places, will they choose, the drug over health care and stability? Yeah, because they don't really at that point have a choice in the way that we think about it. People with a heroin addiction or an opioid addiction or an alcohol use disorder, or any of those, do not wake up in the morning and write a freaking pros and cons list on the refrigerator. They don't do that. What they do is they make a fundamental choice of, do I survive today or not? And it is that dire. And when I talk to my patients over and over again, and when I see them in the community or I see them in the clinic, and I ask them, what's the first thing you think of when you wake up? And their first thing Please don't let me use. And then immediately after that, how can I get something to keep me from not dying? I mean, this is the fundamental aspect. This is the every 4-hour reality of patients with addiction. So when we look at this, what do we do with somebody who has low dopamine, who doesn't create that? We know if they have low serotonin, like in depression, we replace that. We have a selective serotonin reuptake inhibitor. We give you a medication to help boost that while we can then do therapies. And then if that continues to work, the literature says after 2 to 3 years, then we can maybe start to wean those. For some people, you can't. And what do we do as a society? We're okay with that because we would like you to not be depressed, because if you're not depressed, you're functional, you go to work, you take care of your family, you get your education, you do these things. What about when we have a low dopamine state? Somebody whose best day now, right? Let's say we find them. So let's say we find they come in and they want help, and we get them off of their drug of choice and we put them in a program to get better. Well, their best day ever is now about 30 nanograms per deciliter. Their worst day is around 10, where they can't even come out of the room to sit in group. Why would we not help them to be functional and functionally restore their capability to interact with their family and with their education and with their jobs and with everybody else around them by replacing dopamine in a safe way? This is exactly what medication-assisted treatment does, is basically raise dopamine back to normal levels. Patients with a long-term opioid use disorder do not have enough dopamine to get actually inebriated or high or intoxicated from these medications when prescribed appropriately. They don't. And so when we look at this, dopamine replacement therapy, if done properly, allows for a patient without question to decrease their mortality rate, to decrease the chances of, in this case, a baby to be born at term, a mother-baby dyad to be developed, to go home as a family and not be separated based on child protective services and now an isolated parent who somebody took their child away. So when we start to think about this disease, this is a neuroscience-based chronic disease. And from that, we have to recognize that unlike many other diseases of the brain, we actually have solid evidence-based treatment. And the solid evidence-based treatment that we have is the stability of dopamine. And with that stability of dopamine comes the capability for them to actually re-engage their prefrontal cortex, high-level decision-making. They'll start to actually do a pros and cons list. They'll start to think about this. The minute that we stabilize that dopamine, they can re-access the memory of, man, last time I made that decision, that didn't work out so well, so maybe we start moving forward in a different pathway. Or I can listen and I can onboard new memories, because without dopamine, you actually cannot substantively onboard new memories. So we wonder why therapy is not working. When we take somebody off of their drug of choice, we don't replace dopamine, and we put them in therapy. What they hear is, rah, 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 rah. And in the back of their brain, they have this siren going off saying, I need dopamine, I need dopamine, I need dopamine. But what we've done as society is we've stigmatized a lack of dopamine and made it as though they wake up every day and want to be in this situation. That they want to wake up and they want to go out and they want to find heroin, that is what they want to do. There is no want in this. It has removed itself from want into survival. And the minute we understand that there is a connection between the neurobiology of what causes this disease and the treatments that we have to actually stabilize that neurobiology, we should be ethically, morally outraged at ourselves that we haven't actually allowed for full-on access to evidence-based treatments that decrease the risk of death, not to just mom, but mom and baby, decrease recidivism in jail, decrease HIV, decrease hepatitis C, decrease infectious disease, decrease family, broken systems, decrease use of the foster care system. These are all have been shown over and over and over and over again. This is not one observational study of unicorns and rainbows. These are multiple meta-analyses that have been put together, data, science, and math. Medicine is built on that. And, oh man, we have made our mistakes. And I think the cause of the largest iatrogenic, problem in the history of mankind, being the opioid crisis, is on our heads. This is us. But right when we're finally emotionally ready as a societal piece of medical care to take care of this problem and really surround this and do this, we're at a place where we still have to bust through stigma, where people are seeing this as a choice when no one chooses this. This is not a choice. Genetics is where this starts. Early life trauma is where this solidifies. And then access to these substances is what just makes it easy. And at that point, when you have those three things come together, what you end up with is someone who had a life path that they wanted that was hijacked based on a combination of early life trauma, misconnection or disconnection with society around them as far as an ecosystem of strength. And then from that, what happens is you now have a person who's at risk, and the only time in which they feel safe is that first or second time they use the substance. And then they're not getting that same safety feeling from dopamine because it's decreasing and decreasing and decreasing, and then it's gone. And then what we do to them is say, suck it up as a society, because we have less than 10% of primary care that even screens for opioid use disorder or addiction at all. We have less than 10% of OBGYN that screens for addiction. So when we have less than 10% of the total OBGYN and primary care settings that actually screen for a treatable disease, that's malpractice at a lot of levels. So when we look at this, there are things we can do. So to set up kind of the next group of people who are the experts who really do this every day, I want to make sure that we're actually solving the right problem. Because the problem I hear people trying to solve in this case all the time is, well, we just need to have babies born without neonatal abstinence syndrome. And so we need to get all the moms off of these medications. Boy, that's the simpleton approach to a complex medical problem, because that's easy. We can put all moms in jail and we can just make them not get it and deliver a baby. Boy, that sounds like America, right? That sounds great. No, that sounds horrible. It sounds unethical. And it sounds like we're not focusing on what really is the problem we're trying to solve, which is the development of a long-term stable mother-baby dyad / a family. And so if we're unable to come to the agreement that what we want is for both of those things to happen, then we're fundamentally not going to be able to develop policy, guidelines, pathways, or even a cultural change to finally coalesce around what we have to do to, quite honestly, what is the only twofer in medicine that I get to treat, which is a mother and a baby. When a mom needs help and we give it and we stabilize the social stratus around them, we help them to understand that they need housing in a stable way, and whether or not that's long-term, housing that we, get them into, or education and a job to be able to support themselves within that. All of that doesn't matter if they die from overdose. If we don't get them into treatment, their mortality rate skyrockets. So when we say we need to get you off of this medication, we quintuple their risk of overdose in the next 90 days. We have 2 patients. We also quintuple the rate of overdose and preterm delivery of the baby. So we're actually causing a twofer in the bad way when we do that. But if we have a mother that we stabilize dopamine, we get her into the therapeutic modalities that have good evidence base behind them, and we move them through that. We then develop a system that will help us to deliver a healthy child at term. We will walk them through in an evidence-based way opioid withdrawal. And then after that, we have a mother-baby dyad that we can send home, create a permanent structure, and allow for mom to know what it is to build a bond with a baby, to know what that's supposed to be. We have that capability. And my colleagues that are going to come up next are going to walk you through the evidence and the data and the science and the math that absolutely shows that we can do this, and we are making a decision not to. It is not a matter of, wow, I wish or I hope. We have the evidence, we have the pathways, we know what systems need to be put in place, and we are making an active decision not to implement them. Thank you.
I just realized we didn't go through all of your great slides, but everyone, they will be available on the flash drive and online at the Institute for Medicaid Innovation. Thank you for that again, Dr. Waller, for a really engaging and eye-opening overview of the opioid epidemic. Your remarks really, truly highlight the significance of opioid misuse in the United States and the importance of today's summit to bring awareness to opioid misuse during pregnancy and neonatal abstinence syndrome in the Medicaid population. As part of today's summit, the Institute for Medicaid Innovation is officially releasing 2 comprehensive reports. I want to thank my colleague, Ashley Hernandez-Gray, for leading the effort to develop these resources. The first offers an overview of opioid epidemic, including current clinical and policy efforts. The second one, which is the focus of today's summit, is on the epidemic in women and newborns, with case studies of Medicaid health plan best practices. For those joining us in person today, a copy of both reports and the infographic highlighting key findings are available on the thumb drive that you received. All of these resources will also be available online at the Institute for Medicaid Innovation's website. To highlight a few of these key findings, the following slides offer a snapshot. Since 2000, drug overdose deaths from opioids have increased by 200%. Not only are opioid-related overdose deaths increasing, drug overdose has become the leading cause of injury death in the United States. Coinciding with the rise of opioid misuse, the national incidence of opioid-related neonatal abstinence syndrome among newborns has increased over the past decade. While this trend occurs nationally, it disproportionately impacts Medicaid-enrolled pregnant women who are more likely to use prescription opioids during pregnancy than pregnant women living above the federal poverty level. According to an analysis of data from the 2000 to 2007 Medicaid Analytic Extract, a fifth of Medicaid-enrolled pregnant women in 2007 filled a prescription for an opioid, with rates varying across the states. As you can see from this slide, many states have adopted laws that criminalize drug use during pregnancy. These policies disincentivize women from accessing evidence-based medication assisted therapy, as commonly referred to as MAT, and places their neonates at increased risk for neonatal abstinence syndrome. While only 3 states consider substance use during pregnancy as a crime, 44 states will prosecute women for prenatal opioid misuse. In some states, opioid use during pregnancy, whether prescribed or illicit, is considered child abuse or neglect and grounds for civil commitment. One of the key features of the IMI reports that are being released today are the case studies of best practices led by Medicaid health plans working together collaboratively with clinicians and community partners to address the epidemic. As an example, we want to share with you an emotional video highlighting the effort of one community in West Virginia. Teresa and Alexandra, 2 Aetna Medicaid members who participated in the opioid program, along with Dr. Sean Loudon, the medical director at Lily's Place, will share their difficult story.
The neonatal abstinence program is a program where when you identify a mother who is using, we try to enroll her in the case management program. We get her into treatment if need be. We follow her throughout her pregnancy. And then once the baby's born, we enroll the baby in the program as well.
The innovative portion of this system is the fact that we're actually trying to take those babies out of the neonatal intensive care unit, put them in other locations where they can frankly get maybe even a little more therapeutic care and environment, still getting medication and still treating their withdrawal. But then that actually opens up beds and resources for those babies who do require neonatal intensive care, so premature babies or sick newborns. That's what a NICU was designed for.
Addiction tears their lives apart. Some of them end up homeless, some of them unfortunately end up dead.
If I was here today and not sober, I don't know that I'd be here. I'd probably be in jail. My kids would probably be in state system.
These programs are important because there are a lot of addicted mothers out there that they don't know what to do and they don't have anybody to turn to.
We kind of act as a social worker as well if they need help with resources in the community.
The groups are helpful. You know, it's kind of a support system. The most helpful thing is that I'm able to stay clean.
Success would be having a full-term, healthy baby who thrives, just a normal baby.
I think if everybody had an Aetna program, there'd be a whole lot more sober people in this town.
I'm able to lead a normal lifestyle, which is, for me, it's the best thing that could have happened.
Aetna Better Health. You don't join us, we join you.
In the audience today, we have representatives and individuals that were shown in the video available to speak with you after the summit. The partnership between Lily's Place and Aetna Medicaid is just one of many examples of stories across the U.S., highlighting how communities and stakeholders are working together. Our panelists today will share more insight into how efforts to address the opioid epidemic are working and to offer opportunities on how to improve these efforts across the United States. And with that, I'm going to hand it back over to Craig.
Thank you very much, Jennifer, and thank you, Dr. Waller. Our first panel today will focus on women, babies, and the opioid epidemic opportunities in Medicaid. We're really privileged to have three experts who will each give some brief introductory comments, and then we will move into questions and answers from the audience. Let me take a moment to introduce each panel member. As I announce their name, they can come up and join us up here at the panel. First of all, Dr. Mishka Turplin. Dr. Turplin is a professor at Virginia Commonwealth University, where he serves in the departments of obstetrics, gynecology, and psychiatry. He's also the Associate Director of Addiction Medicine. Dr. David Oguret. Dr. Oguret comes to us from Temple University, where he is an assistant professor in family and community medicine and involved in teaching the next generation of physicians about the importance of medication-assisted treatment. Finally, but not lastly, of course, Megan Barton. Megan has a remarkably diverse background in nursing and will share with the audience successes at Home State Health in face-to-face case management. And she actually brought with her today one of her Medicaid members, Emily Keener, and Emily is later going to share her journey of recovery. Before we begin, index cards have been provided to you on your seat to write down questions that may come up while you're listening to the panelists speak. When writing your questions, please also include your name and organization unless you want to be anonymous. During the Q&A session, at the end of the panel presentation, we will ask you to pass your index cards towards the front of the room. I think we are ready for the panel. Dr. Turpin.
Good morning. Thank you. And thank you all for coming. I want to begin by answering the question, what happens when women who use drugs become pregnant? And on this slide, you can see the blue column are reproductive age women, the percentage that have used a substance in the past 30 days, and the subsequent columns are by trimester stratified alcohol, cigarettes, and illicit substances. And you can see that most women quit or cut back during pregnancy. And I look at these data, and to me, how do you advance that button? These data support the statement that all pregnant women are motivated to maximize their health and that of their baby-to-be. And most women quit or cut back substance use, but some can't. And those that can't have a substance use disorder. In fact, you can think about pregnancy as a natural experiment that separates use from use disorder. And we just heard a wonderful talk about addiction and what addiction is. And as an obstetrician, sometimes we keep things very simple. To me, addiction is a brain-centered disease, the symptoms of which are behaviors. And the most salient feature is continued use in spite of adverse consequences. Continued use in pregnancy is pathognomonic for addiction. So when we talk about this, we're not talking about people who develop addiction in pregnancy. We're talking about people who have addiction, who become pregnant and stay pregnant. Now the treatment is, we treat addiction, behavioral plus medication, and for pregnant women, co-located with prenatal care. And we've known this since the 1970s. This is the first article shortly published after people started utilizing methadone in general, which demonstrated that women who received comprehensive co-located services, i.e. treatment for addiction and prenatal care, their birth outcomes were identical to a general population of non-addicted women. In 1978, Loretta Finnegan looked at this and contrasted it with an untreated addiction. So pregnant women with untreated addiction, in this case, had 50% of them had a preterm birth. But women with treated addiction had a preterm delivery rate that was very similar to, if not to, the general patient population. So because of this, in part, the treatment of pregnant women is a federal priority. In fact, pregnant women should get priority access to treatment and do not need to meet the same DSM criteria in order to receive pharmacotherapy. But do pregnant women really receive priority access? These are data from the National Survey of Drug Use and Health. 20%, only 20% of women who met criteria for having a substance use disorder during pregnancy reported receiving any treatment, a proportion that was equal to non-pregnant women. How about amongst women with an opioid use disorder? These are data from CDC that was focused on several hospitals in southern Florida in which there was a series of looking at neonatal abstinence syndrome. But to me, the most interesting piece of this document was that only 40% of those women who delivered a baby that developed neonatal abstinence syndrome were in treatment. In fact, only 10% of those moms received any counseling or any referral upon discharge from labor and delivery. Now, the evidence base for treatment, as mentioned, is pharmacotherapy plus behavioral counseling, methadone or buprenorphine. So I looked at, these are amongst women with a primary opioid use disorder in drug treatment in the United States. 50% are receiving pharmacotherapy, a number that has not changed in 20 years. So when we put this all together, there's the population of women who are pregnant and have an opioid use disorder, of whom maybe 40% receive treatment. Of them, maybe 50% are actually receiving pharmacotherapy, of whom a smaller proportion are receiving integrated co-located services, which is the standard of care and which has been described since the 1970s as how to treat these women. Now, this is important for many reasons because the Government Accountability Office cited access, lack of available treatment, as the biggest barrier to care, which is true. In fact, less than 20% of programs, treatment programs in the United States have specific programming for pregnant or postpartum women, a proportion that has decreased over the course of this crisis. We have chosen not to take that little circle that I showed you of integrated co-located services and expand it to the overall population. We have chosen punishment. And oftentimes, the logic to punishment is, well, this pregnant woman didn't go to treatment, therefore that justifies a punitive response, even though treatment doesn't really exist, as I've showed you. In fact, almost every single state in the country has prosecuted a pregnant woman for drug use. And when you look at this, which was mentioned before too, these are state policies. The weight of state policies is on the punitive side, writing state statutes that make drug use identical to child abuse, civil commitment, mandatory reporting. The proportion of states who actually protect pregnant women against discrimination or truly provide in some statute-based form priority access is far lower. So this is really, we have a moment, and I am really gladdened to see all these people here, and us talking about the opioid epidemic. There's going to be other drug epidemics, but the attention we have right now is an opportunity to put things on the ground, to build clinics, to waiver providers, to roll back the war on drugs, and to provide a means that we can really treat women and their families with science, compassion, and dignity. Thank you.
Good morning. As was mentioned, my name is Dave Ogorek, and I am humbled to be here among experts, of which I don't consider myself. I'm a family physician, honored to represent the American Academy of Family Physicians, and want to talk a little bit about the family-centered perspective and family-centered care for patients struggling with substance use disorders, and how promotion of healthy moms leads to healthy babies, which ultimately leads to healthy families. Some of the material we'll be discussing, you'll see common themes throughout the morning, and I think in terms of the delivery of care and the care model to care for, again, patients struggling with substance use disorders and their families, that they must be integrally part of that care, must be multidisciplinary and it must be multimodal. There's no magic pill, there's no magic wand that fixes things just with a single element. Patients are at different points along the spectrum in terms of stages of change of where they would like to be. And therefore we need to start with prevention, and we need to start with prevention for women of childbearing age, thinking specifically about preconception care and that model of care in terms of identifying and triggering models to address care needs of women before they even get pregnant. Looking at educational programming for the communities as well as the physician communities, addressing chronic pain and being more evidence-based about how we address chronic pain, as well as increasing our evidence to help our doctors manage chronic pain. There are guidelines out there that fall short a little bit on high-quality evidence for what is the best treatment for chronic pain, and we need to improve that to help our communities address their pain. But the harm reduction piece is critical as well, because people may not be along the spectrum where they're ready for medication-assisted therapy, and certainly forcing people to do something that they don't want to do or they're not ready for is not a solution. So in those situations, certainly harm reduction strategies are critical, and improving our overdose education and naloxone distribution programs and making those things more accessible to patients from a cost perspective and not be cost prohibitive or community prohibitive. Also looking at innovative models at syringe exchange programs as well as supervised injection sites. That evidence has shown to get people into care who otherwise may have not engaged in care. And these are critical community and public health forces that can help. The treatment piece, obviously medication-assisted therapy we talked about this morning, but it must be integrated into behavioral health services. There must be counseling services, and that's critical to the medication-assisted therapy. The medication alone does not fix the issue, and it's not the catch-all. Linkage to primary care services, obviously as a family physician, we're passionate about primary care and noting that it's not just the addiction care piece that needs to be addressed, but care of co-occurring disorders, mental health disorders, as well as chronic disease management. Screening for HIV, hepatitis C, chronic diseases, and then the treatment for that. But the other critical piece is both during the treatment piece and after the treatment piece, and those policy pieces for integration services of patients back into their communities. Linking with medical legal partnerships, ensuring that there's vocational rehabilitative services where individuals who are in recovery and doing very well but are having challenges getting jobs and getting out there because of continued stigma. And I think the stigma is something that we absolutely have to address, both from a community as well as the medical profession. I certainly see it along many of my colleagues that there's still a stigma and there's a lack of acceptance of this as a chronic disease, much like anything else that we're treating, and that needs to be addressed. So the pregnant mom or the woman of childbearing age fits at the center of this. We need to be patient-centered, and there's a number of factors, social determinants that both negatively and positively affect their health. Within that, they're in the context of either a biologic or a social family. And the importance of the health and wellness of that family, not just delivering health care, but delivering health to that family, fits within the context of a patient-centered medical home, with foundations being things like medication-assisted therapy and behavioral health care. But that unit can't do it alone. Care needs to be integrated across multiple lines. We need to develop a medical neighborhood of services that link the patient together in a much more integrated fashion. We need to pull in specialty care. We need to integrate the pharmacy. We need the inpatient and residential facilities. We really need our critical public health agencies and connections, those pieces about supervised injection sites, syringe exchange programs, nurse-family partnership, the WIC program, children and youth services, and link all those programs together to work together. as well as additional neighbors, including legal services, Capitol Hill, educational institutions, the insurance companies, the employers, to really provide wraparound comprehensive care. If we're going to provide care, let's make it comprehensive for patients that not only address their addiction, but addresses the social situation, their circumstances, and again, improves their health. Let's not deliver just health care, let's deliver health, let's deliver wellness. In terms of the family-centered care piece, we heard a little bit earlier about childhood trauma, and obviously the big study is the Adverse Childhood Experiences study looking at ACE scores, a series of questions that individuals go through about experiences they had during their childhood. And scores of 4 or greater show that individuals are more prone to developing both chronic disease as well as substance use disorders later in life. Now, that's not a destiny. If you have a score of 4 or greater, you are not destined to do that. If we can put individuals into incredibly supportive environments, if we can treat things early on, if we could address care early on, you could change that profile, you can change that product. So thinking about chronic pain and addressing chronic pain, none of our scales look at ACE scores to see if perhaps this person may be at higher risk for a substance use disorder. Thinking about treatment of a mom or a woman of childbearing age for their substance use disorder and improving the situation for her baby long-term. Treatment and removing that piece from the household, from the environment growing up, alters the path of that child long-term, that reduces their risks for things like chronic disease as well as substance use disorder along the road. So when thinking about this and thinking about promoting families, I think it's important to be talking about ACE scores and looking at this and thinking about childhood trauma and childhood experiences. The other piece that's critical, and I mentioned preconception care earlier, is it's not just for the mom. Preconception care is for the significant other in the relationship as well, be that a male or a female partner. Because if they're using and there's a substance use issue there, the chances of that individual, of the pregnant mom getting better is reduced. So we need to treat in the context of the family and address the significant other as well and make sure that the family in general is healthy and treat everybody. I included some resources that will obviously be in your handout. These are some policies as well as white papers from the AAFP that deals with our preconception care ideas as well as integration of primary care and public health and the integrative care models that we think are important to delivery of health just in general. The paper's not specific to substance use disorders, but certainly addresses all care and is applicable to that as well as some of our other papers. And I look forward to the Q&A session. Thank you.
Hello, I'm Megan Barton. I am from Centene. Home State Health is the Centene plan in Missouri. In Missouri, we noticed the issue that everyone here has been talking about, and we developed a case management program to provide the wraparound services that have also been talked about. So part of the case management program, the first step is identifying our members. So how did we start that? How do we find the members, or who is it that we need to see and could utilize our services of case management? So we mine our data for substance use. We look for diagnoses. We go back through any historical data, any current data, looking for any diagnoses that might indicate that someone has substance use. And we also look for prescriptions, if there's a prescription for narcotics, or if there's particularly a refill. So if someone's refilling a prescription, that sends a trigger to our case management team. We have partnerships with the C-STARs across the state. So if someone is admitted to a C-STAR, they actually call us. They say we have a home state member. They call our case management program, and we'll send a case manager out to them and visit them there on site. We perform telephonic outreach to all of our pregnant members. So historically, we have performed all of our case management telephonically. And for our substance use members, I felt that maybe a more personalized program would be something that would help our members better. So that is how we started our face-to-face, but we still do telephonic outreach to everyone, trying to do a screening to see if there's any need, any criteria that would fit somebody into our face-to-face program. So when we identify our members, what we do is then we do our outreach and start to do contact to them. And this is the tricky part because we can't always locate our members that we've identified could really use help from our program. So locating it often is a collaborative efforts with the provider. So we have our historical claims data. We can call the prescription. We can call the pharmacies. We can call the providers that they've seen. We can even call EDs if they've been there and see if they have a telephone number, an address, what's the most recent thing on file. And we will do telephonic outreach. If we cannot reach them by telephone, we will drive by their house, the most recent address we have on file. So when we're driving by the home, we're not always going to locate a member there, but we have located maybe a family member or even a neighbor who can point us in the right direction, and that has been successful in locating our members too. So program components, we find someone and we start talking to them. It's a nurse case manager who's there, and it's personalized case management. It's done in the member home, at the care setting, so either at the C-STAR facility. We've actually met members in church parking lots, at playgrounds, at fast food restaurants, wherever it is that somebody wants to interact, and that member can get the best experience and feel that a trusting relationship. Our case managers do a comprehensive assessment. They're looking for barrier identification, so the things that we've been talking around with wraparound services. What are the social supports that are needed? What are the different things that are in their life that are keeping them from making healthy decisions for themselves and their baby? And we try to alleviate those barriers. We facilitate enrollment into specialized local programs, so the things that we've been talking about, even enrollment into C-STARS if they're not in one, helping them get hooked up with methadone, Suboxone, those types of things. Linked to community resources, so if there's things such as food, clothing, shelter, utility assistance, helping them navigate through the system to find those resources that are out there. We have attended appointments with members, actually gone to the OB if that's what's going to be the motivation to get them there and to help them make those healthy decisions. And it's a lot of frequent contact and just helping them through and helping empower them to make healthy decisions. So the goals of the program is we are trying to decrease substance use during and after pregnancy. We are trying to move the members into different programs in the community. We have people help them in methadone or Suboxone. We are trying to increase the gestational age for the delivery, decrease our NICU admissions or the length of stay. So decreasing the length of stay, if it would be just decreasing the morphine weans that have to go on for the NAS. Decreasing or active member personalized goals, so working with that member. And sometimes it's just setting little goals. Maybe it's not this overall, let's make the world perfect, but just working with them. What do you want to do? Where do you want to get? And how can I help you get there for that personal achievement? And then empowering them going forward that once we have to take a step back, that hopefully that member then has all of the tools and resources they need to have a healthy family and to make those good decisions going forward. So that is a face-to-face program. We do have a member who's here with us today, is Emily, very brave member, and she's brought her beautiful children. Her baby is 6 months old and back in Missouri still, but she does have her 2 young ones here, and Emily's going to come up and tell about her story from one of our face-to-face nurses who visited with her.
Hi, my name is Emily. Where should I start? Love you too. Okay, so let's see. My eldest is 8 years old and my second is 6. Due to have an emergency C-section with my first daughter, when I had my son Caleb, they just recommended to go ahead with a C-section due to we didn't want the scar to rip. Of course, I was sent home with opiates, prescribed opiates, and with 2 young babies, it gave me a lot of energy, and I was quickly addicted to opiates, to prescription opiates at the age of 23, when I hadn't done drugs before that. So years of hiding it, I was a single mom taking care of my children. They gave me energy, so I was buying them off the street from whoever I could. Nobody in my family even knew. And eventually one day before work, I could not get those, so somebody introduced me to heroin. And it went downhill from there. I hid it from my family, from my friends, because none of my friends used. But you can only do that for so long. So, of course, my life started to fall into shambles. I couldn't hold a house. I couldn't pay bills on time. I couldn't keep a car. It was just a vicious cycle. And then 2016, last year, I ended up losing my father to cirrhosis of the liver because he would not quit drinking to get the medical help that he needed. And my parents were married for 35 years. So after that had happened, I went to Bridgeway because I wanted to get help, which is a treatment center in St. Louis, Missouri, and it's one of the best treatment centers there is. After 30 days of attending there, I came home, and my mother was very sick without my father, and after like 10 years of recovery herself, she started using again. And about 2 months after my father died, my eldest and myself found my mother on the bathroom floor to an overdose. So, of course, I relapsed. I didn't know what to do and how to handle the pain. But after about a month out, and I had just found out I was pregnant. I was about 3 months pregnant at that time. And I'm not unintelligent or uneducated. I'm very well aware that using during pregnancy, I was going to end up losing my child and possibly my other two along with it. So I went back, called Bridgeway, and I just begged them, please let me come back. And usually there's a long wait, but luckily they let me come back like 2 days later. And that was in August 8th of last year. So I attended Bridgeway, and I was a wreck because I just lost both my parents. My kids were with my only sibling left, my brother, because my sister had passed away too. So I was hopeless. I was ready just to give up. I was already far enough that I didn't think abortion was an option, and I didn't believe in abortion. I was very confused. And then the program coordinator at Bridgeway came and got me and said, somebody's here to see you. It's a case manager from your insurance company. And I've always had Medicaid. I had no idea. I never even met somebody in person from my insurance company. So I'm like, what does she want? I was very paranoid. I was paranoid because I already knew that I had got myself in a very bad situation. I was severely depressed. I was angry at myself and angry at the world. So when her name was Susie Couch, and when I first met her, she was basically, just went through like what they offer. We can help you, this and this. I can go to doctor appointments with you. And I'm like, who the heck are you? Like, I don't need you to go to a doctor appointment with me. Like, I'm probably not even going to be able to keep my daughter as it is. Or I didn't even know it was a girl yet, but my baby as it is. I'm worried about losing my other two kids. Are you working with Division of Family Services? Because that's, where my mentality was at that time. And she swore up and down she wasn't. She asked if she could come see me again. And I don't know why, but I agreed because I was really bitter back then. But I did agree. And after about 3 or 4 visits, I think I fell in love with Susie. She became my best friend. I had no support. My mother and father were always the ones that were there for me and my children because their father was not the best. And Susie showed me support. She came to an OB appointment with me, and I remember when she asked, I did feel sort of uncomfortable, but then when she came with me, it was when they offered me medical or pharmaceutical help, and I didn't personally want to go with methadone because of the high rate of addiction with that afterwards, and I was nervous about anything, but they did get me on Subutex, which is a form of buprenorphine, and I did continue with that for my entire pregnancy. I finished Bridgeway, I joined NA. I had nowhere to live because when I joined Bridgeway, went to Bridgeway, I obviously had to quit my job. And so I lost my apartment because I couldn't pay the rent and had no family. So I had nowhere to go. All I know is that I wanted to get sober and I wanted help. And I didn't know how I dug myself into this hole. Nobody wakes up and says they want to be an addict. It doesn't happen like that. You don't wake up and say, I just want to wake up and do some heroin. It doesn't work like that. I never thought that would have been me. I know I don't have much time, but basically, yeah, I gave birth to a beautiful baby girl that was completely healthy, full term. She's amazing. She did go in the NICU for about 8 days, but it wasn't due to withdrawals. It was actually something with her lungs. She was amazing. She's an amazing baby. As far as I can tell, she's happy. Things have come together for us too. It takes time. If it wasn't for Susie had got us into a shelter, which I wasn't thrilled about at first, but it was a women's shelter where I could take my children with me. And it was actually like a home. She found me resources everywhere. From that to oh my gosh, anything for the baby. She's the one that introduced me to the Wish Clinic that is ran by St. Mary's in St. Louis, Missouri. The Wish Clinic is also phenomenal, and I will give all the credit to them. Their doctors are so compassionate, and for not having a mother and father and being as pushy and as I was and not wanting any support, these people, I mean, they were amazing. They gave me love when I didn't feel like I deserved to be loved. And I think that's where a lot of the anger comes from with addicts, is that they don't love themselves anymore. But I feel like nobody should give up. Don't give up on them, because here I am today, and my parents have only been gone for a year, but I now have almost 11 months clean. I have full custody of all three of my children. When Division of Family Services came into the hospital, because they have to if you drop for any paraphernalia or any drugs, throughout your pregnancy. So when they came, they closed the case that very same day, because I had already went to Bridgeway. I had already done all the stipulations that normally she said that she would tell a mother to do and have to take the baby. And I only was able to do that because Susie, my case manager, when I asked her, what do I do? I don't want my daughter to be gone from me for one day. What do I do to be able to keep her? And she told me, this is what you need to do. I'll help you get in it all and get it done. And I tell you, that Division of Family Service worker was wowed when she came in, and I already had completed everything, and had never even met me. And I had it all done. So Home State, the face-to-face program is amazing. I wasn't paid to come here. It was voluntary. I actually still keep in touch with Susie. My daughter's 6 months now, my youngest, and we go to lunch. She is actually my friend, and I'm grateful for them. They saved my life, and I believe strongly in all these programs. They will help somebody, and just don't give up. I know it seems like people don't believe it's a disease, but nobody wakes up and wants to be like that. So thank you.
What an amazing story of courage and recovery. Thank you so much. Thank you so much. I was going to save this till later, but I just can't wait. It may have to do with my dopamine receptors here. On behalf of all the speakers, we had the privilege of having breakfast today with Emily and her delightful family. We wanted to give you a certificate of appreciation, a card signed by all the members, and last but not least, a goodie bag.
Oh, thank you.
And she really deserved that standing ovation. So now we're going to move into the question and answer period in a few minutes. As a reminder, if you have questions for the panelists, if you would write them down on index cards and pass them to the front, Jennifer will kind of help gather those for us, and we can have all the questions you have about those slides. As a reminder, all those slides will be posted. There was a lot of important detail on them, so we'll have a chance for people to look at those in more detail later on.
You're so sweet. Sit down, buddy.
The first question is, can you please talk a little bit about screening? And this must have been written by a physician. Can you talk about screening and the treatment of co-occurring HIV and hepatitis C? How is it different, if at all, in this population?
So in terms of screening, there's obviously a number of validated screening tools that are out there and available for screening. I don't particularly endorse one over the other, but there are multiple tools both in the adolescent and adult population for both opioid screening as well as alcohol-based screening. Looking at the evidence currently, if you utilize sort of the United States Preventive Services Task Force guidelines, the only evidence-based screening right now is specifically for alcohol population-based screening with utilization of SBIRT in individuals 18 and older, but that doesn't mean that there's not value to screening for opioids and other substances. And obviously, as I mentioned, there's validated tools for that. The guidelines looking at screening for opioids are currently under review by the USPSTF, so those recommendations may change. In terms of treatment for co-occurring disorders, mental health disorders or things like HIV and hepatitis C. With HIV and hepatitis C, it should be viewed as no different than any other individual. In terms of treatment of co-occurring mental health disorders, obviously thinking about medications and generally any medications, thinking about whether or not things pose a risk. Obviously, co-use of benzodiazepines in an individual on medication-assisted therapy is not recommended. And thinking about when you're prescribing a medicine, is there an addiction potential to this? Is there an interaction potential? I don't think care is honestly any different than you would provide to anyone else and shouldn't be viewed any other way. I think thinking along those lines might make a sense that furthers the stigma. Obviously, there's unique components that you want to address, but nothing specifically that makes it drastically different from my perspective.
Thank you. Other comments?
I would just add that I've stopped using the word screening when I talk to people and changed to use the term assessment. There's screening tools, and this is a separate conversation, but substance use, misuse, and addiction are common. They intersect with all other health conditions, and it should be a routine part of every doctor-patient encounter to do an assessment of whether or not somebody's using, misusing, or might have a substance use disorder.
Thank you very much. We have, I think this says something about the effectiveness of the panel. We have about 5 questions for Megan. How many individuals are served by the Home State Health Case Management Program, and how many case managers do you use dedicated to the program? And as a follow-up to that, do you also use peer support specialists as a part of the program?
Okay. Are these on? Or
That's so many, I'm going to give you the card.
Okay, yeah, the multi-part question. So, how many individuals are served? I think right now we have just around maybe 125 enrolled at any given time. It's kind of a rotating number after delivery, or sometimes we do lose contact with members. How many case managers? It's half of our team. So there is a team, so I have around, going to say 20 face-to-face case managers located across the state. And those are all nurses. And use peer support. I have been looking for peer support across the state. I don't have one of my own. I have reached out to the different entities across the state to see if they are peer support groups. There's actually I find in Missouri, I don't know if this is happening in other states, there is a real need for some peer support groups. There was one called Mother to Mother, and it dissolved a few years ago, and that was in the St. Louis area. But the WISH program that Emily was talking about, they have one, yes. And I think, and we link moms up with that. But there is a high need for more of them. So I've been working with the CHBCs around to see if they have some programs that we can do. Yeah, I know.
I was going to say, I would love to help anyone. Yeah.
People may know this, but a peer support specialist is someone who is either in recovery or has lived experience, or maybe the parent or family member. And there are training programs throughout the nation which are very effective because it means something to talk to somebody who's traveled the path. So thank you for that. Next question we had is what is preconception care, and what opportunities exist to address opioid misuse with preconception care?
So preconception care, from our perspective, is essentially primary health care to women and men of childbearing age. So it's essentially an umbrella term that covers care of someone of childbearing age, be it a man or a woman, before pregnancy or in between pregnancies, which is sometimes referred to as interconception care. And there's a number of evidence-based strategies, largely in the female population, specifically targeted at risk factors that could be addressed before someone gets pregnant, that ultimately affects the outcome of the pregnancy and reduces preterm birth, as well as complications related to that and complications related to the pregnancy. Obviously, in terms of the process itself is honestly about discussing with a family what are their plans for having children, and when are they thinking of doing that, and making sure in terms of management of chronic diseases or other processes that are going on, that individual is in the appropriate state, physical, mental, behavioral, at the time to carry a healthy pregnancy and to have a healthy baby and lead to a healthy family. So obviously if a mom has chronic pain, addressing sort of some of the chronic pain issues and discussion about what might be involved in that if they already are on opioids for chronic pain or other medications, and perhaps adjusting that and speaking with that about what would be involved during a pregnancy and the relationships with that. It often doesn't happen because you know, we find out someone's pregnant when they come into the office. We don't deliver. That piece isn't a standard routine part, sadly, of well care. You know, many women of childbearing age now that, you know, their routine PAPs and those sorts of pieces are spread out. They may not be coming in yearly anymore in terms of their exams, sort of just coming and catching for acute visits. So the chronic preventative piece is addressing those components that would improve, again, their overall health. But as a component of that, you can address multiple factors that leads to a healthy pregnancy and a healthy baby.
Thank you very much. This question is from Dr. Shaya. Dr. Shaya is a professor and vice chair of academic affairs at the University of Maryland School of Pharmacy. Given the large scope of the SUD, substance use disorder issues, should we expand our educational programs, especially for health professionals, to include addiction science, prevention, treatment? Are we doing enough in education, also for the general public?
Of course, yes, and we're not doing enough. So probably, we've been talking, those of us here, like I'm one of 5 physicians in my institution with a buprenorphine waiver. 800 physicians, there's 5 of us who can prescribe a medication. Probably the main predictor of whether or not a physician in training incorporates addiction into their practice is exposure, either clinical exposure or like educational exposure. There's lots of efforts to integrate more about addiction into curriculum. Medical school and other health professional curriculums are already stuffed really full, and there's lots of competing priorities. I think probably when I think about how I might structure exposure, most of what we see in the public as trainees, as physicians, is untreated addiction. Is somebody who comes to the emergency department following an overdose, goes right back out, uses, comes back with an abscess, goes right back out, uses. That's the image we have of what addiction is, and that's the image of untreated addiction. Imagine if all we understood about diabetes was untreated diabetes. People coming into the emergency department with gangrenous wounds, getting, an amputation, going back out, coming back, and the amputation now becoming gangrenous. We would think that's a hopeless, fatal, disease that we can't do anything about, and it's their fault for not taking better care of themselves. So what I would like to show medical students and the general public is what recovery looks like, what treatment and recovery looks like. And we actually see recovery all the time, but because of the stigma associated with this condition, we don't stand up and sort of share that as much.
Yeah, I would echo those comments. I think it's definitely needed, and it's needed more, both in the medical schools and all the health sciences schools in terms of exposure to addiction treatment, and the positive sides of things. And I think the community absolutely as well. I strongly encourage all the medical students to go to an open AA or NA meeting and see what it's like. And I think just for the community in general, having that experience is really eye-opening.
Thank you.
I just want to state where we are. We can only do better, given that the average medical student leaves with less than 1 hour of training in addiction. The average resident leaves with less than 1 hour of training in addiction, and it's the same for pain. There's not one medical school in the United States that has mandated, integrated into their curriculum, learning or teaching about addiction or chronic pain management on a standard basis. And that happens actually at the medical school national level, because to them, it's more important to learn about a pheochromocytoma, which is a once-in-a-career tumor, than it is to learn about the #1 cause of injury-related death in our country, which is overdose. So I think that we are failing at educating the next generation of doctors, let alone the group of physicians who need to be educated, who are actively practicing. And all but 2 national physician groups actually are against mandating education. So I think that we have a cultural conversation that we have to have amongst ourselves about how we feel about education in this area.
Thanks so much. The next question is from Navina Miner. She's with Medicaid and Ship Payment and Access Commission, and this was directed to Megan Barton. Do federal confidentiality regulations, specifically 42 CFR Part 2, hamper, people recognize that, hamper the ability of care managers of home state health to connect and exchange information with other participants in the care?
So that's a good question. When somebody is trying to think of if there's an easy answer for that, we're not out shouting it from the rooftops. I don't know. We share information if it's pertinent information. We have checked through our compliance department on the different things. So if it's a substance use as opposed to like a health issue, where is the definition of what this is? So I think that's why we have our case managers really taking the lead and just kind of going with the member and having them speak. We're not sharing the information. We're encouraging them to share the information. And we're not out just calling the physicians and saying, hey, did you know so-and-so is out here doing this and this is going on. We're really just empowering the member to take that role. So we haven't run into that. I know that with our sharing of between providers, I guess would be what it is. So if you're telling one provider, did you know that this member is taking an opioid, or different things are going on, we aren't sharing that. We are just empowering the member to share it. And that's how you get around that, or actually not get around it. That's how you fix that.
Can I make a quick comment?
No.
It's important to understand that 42 CFR Part 2, especially with the new regulations, actually doesn't apply to the payer. It applies to someone who holds them out specifically to be a provider of addiction treatment. If the information that goes to the payer comes from that entity, then it lives under the world of 42 CFR Part 2. If, however, the information that is gathered by a payer comes from a general hospital or a primary care office, it's not held by 42 CFR Part 2, and it lives under HIPAA. Very specific. The new Part 2 also allows for coalescence of data and releases to allow us to release information to a care team without having to specifically specify the caregiver. And those are changes that have just happened in Part 2. It's overinterpreted by risk and compliance officers because their only job is risk and compliance, not patient outcome.
Yeah, I'm so grateful to you for saying that, because yes, that's where I kind of run into the risk and compliance team. I'm like, where are we doing what's best and where are we just kind of creating our own barriers? So thank you for the information. We're going to relook into it immediately.
So the next question says, when state laws regarding drug use and pregnancy are punitive, is it worthwhile to conduct drug toxicology screening in prenatal care? Please speak to the consequences and advantages. There's going to be some thinking on this one, I guess.
So I had a slide that had a Supreme Court decision on it, which was Ferguson versus City of Charleston, 2001, I think. This is a Supreme Court case, a class action lawsuit brought against the Medical University of South Carolina. During the 90s, the era of crack cocaine, they were selectively testing pregnant women on labor and delivery with urine toxicology. Those that were positive for cocaine, they were reporting to the police. The police were coming and arresting women from labor and delivery. All but one of the women arrested were black, all were poor. A class action lawsuit was brought against the medical university, and it was ruled by the Supreme Supreme Court that this was a violation of their Fourth Amendment because they had not consented for these procedures. That still stands as the law. I think there's been a movement towards universal drug toxicology testing on labor and delivery. I am not sure if all of the consent forms being done in the United States are actually sort of adherent with the law. If that's the law for labor and delivery, I kind of feel like the spirit or the ethical frame applies retrospectively through into prenatal care. And that if we are going to utilize some sort of biological testing, it has to be transparent and there has to be consent for it. That being said, like, what does a urine drug test tell you? It tells you whether there are metabolites of a substance in your biological compartment at that moment in time. It doesn't tell you whether or not it doesn't tell you anything about behavior. It's not a diagnostic test for addiction. Addiction is a brain-centered disease. The symptoms are behaviors. There's nothing about a urine drug test that tells you anything about behaviors. It certainly doesn't tell you anything about whether or not somebody is going to be a loving, caring mother. So, I think that we use it as a convenience and in place of doing what we kind of should be doing, which is having conversations with patients about their lives and health, which include substance use. And I think if you're going to use it, you need to then state what the consequences of a positive test result are.
Thank you very much. Other comments on that? I guess what I would add is I think it's really important for us to look at how we frame the findings that we have in testing, isn't it? Is it a positive test? Is it a negative test? Is it a clean urine? Is it a dirty urine? Think about the language and what impact that has in terms of promoting or changing stigma. The next question goes to Megan Barton. Can you please explain when a person gets MAT, which we now know as medication-assisted treatment, is counseling required, and who provides that counseling? Substance use counselors, social workers, psychologists, and others? What approach is used? Cognitive behavioral? To let you know I'm not making these up, I'm going to hand this over.
It's like that's a big part question. When a person gets MAT, it's not required. Yes, substance use counselors do that, social workers, psychologists. It's actually just what's in the community at that town. I mean, there's a lot of different resources across the state of Missouri. So if you're in rural Missouri, you might have a social worker. If you're at a big hospital system and they have a program, you might have a psychologist. It just really depends on what's going on. It's not mandated. We just try to link people up with those resources that are available to them, and highly encourage that. So what approach is used? Cognitive, behavioral, is a family involved. So it just starts really with the member, and it's what does the member want to do and who do they want to involve. We don't go out seeking and requiring the family be enrolled, but if the member wants to reach out and have the family, we would give them the resources for that, definitely. It's just up to the member goals for that, and the approach is used is just, it's kind of a, there is no cognitive behavioral, I mean, motivational interviewing, we do some of that, substance use training. It's just nurses having a one-on-one personalized relationship and using their clinical judgment and their historical clinical expertise. We have OB nurses that do this, and they just have interacted a lot with different types of deliveries and seen a lot of things and worked with a lot of OB providers, and they're very comfortable going into members who are pregnant and speaking to them about this. And we just hire people who we feel would be a good fit and build that good relationship. So paint a picture of what is required counseling looks like. So, you know, Emily was saying something about about required counseling, because it's not required, but if you want to take the right steps, like she was saying, DFS came in and they weren't going to take her because she went to the different things. But I'll let Emily kind of talk about what her counseling experience was like.
So, is that right? Okay. So for me, when Susie had helped me find the Wish Clinic, because I explained to her it was my second time in treatment, and that obviously if I didn't do this right, my biggest fear was losing the baby, because at that time I didn't really care much about myself. It was more for the kids. So when I went to the Wish Clinic, I think it's more on where you go to get the medication-assisted treatment and what their requirements are. So at St. Mary's Hospital in St. Louis, their requirements are that you must have counseling in order to receive the medication. You must be involved in counseling, but they provided a social worker there too who checked on me, and she also informed me what I needed to do to make sure the Division of Family Services did not take my daughter, and then I was on the right track. I know it's highly required because, as is any of those substances, you can get addicted to anything. So if you're not properly taking the buprenorphine or the methadone, you can get addicted to that too. And I feel like medication can't help everything. Just like a child my son has ADHD. You can give them medicine all you want, but if there's not counseling involved, then what's the point? You have to work on it. You're with yourself. So. I just feel like if the caseworkers encourage you to do that, it's one step at a time. I feel like the medication would be the good first step because that's getting them off the drugs, first. So that's something off their shoulders. Then encourage them that it doesn't have to just stop there. You can take it a step further. How about some counseling and treatment so that you can also, that goes with wellness, learning to love yourself again. And, all those are key to staying sober. I believe so.
Can I just comment?
It's not required, though. You can go to a methadone clinic, I know, in St. Louis and receive methadone because regardless, they want the baby to come out healthy. So I know that it's not required everywhere.
Thank you. Dr. Gurrit?
I just wanted to comment as well. I think an important thing to recognize and acknowledge as well is barriers to counseling at times. Patients on medication-assisted treatment will oftentimes go to group sessions or go to meetings and hear and are told that they are not in recovery. They're not sober because they're using a medication-assisted therapy and they're just using a substitute for the drug, which discourages people from going back to those locations. And it's certainly a barrier and something that could set a patient back.
Thank you for sharing that. Think about what your doctor says when you go get your insulin refilled and your pancreas is not working.
Yeah, right, exactly.
This question is from Rebecca Abbott of the March of Dimes. I think we have time for a couple more questions, do we? Okay. This is, to me, the most interesting part. Not that the presentations weren't wonderful, but we're really getting some interesting information here. Can you discuss the challenges posed by Medicaid coverage ending for moms with opioid use disorder after the covered postpartum period? Not everybody may be aware of that, so maybe one of our doctors could explain how that works or doesn't work.
So certainly we've had situations where the coverage ends sort of at the 6-week postpartum. So trying to fit in sort of the postpartum visit within that 6-week window, fit in the visit to make sure that they can get enough medicine to last them until we could figure out what sort of insurance plan or what sort of next step there might be for engagement to continue. I think sometimes there's just this assumption that after pregnancy, okay, they're not going to need it anymore. The only real time that they needed it was just for the pregnancy itself. But again, thinking in family-centered care, yes, certainly during the pregnancy, it's something that is important for a healthy pregnancy, a healthy baby leading to a healthy family. But if the mom's cut off and now all of a sudden doesn't have access to services, it's a similar situation. And now you have a child involved or multiple children involved, and the mom's at high risk for relapse, just being stopped of the medicine randomly, and these services without a clear integration or program continuing. So it's certainly a real challenge in those situations where moms just sort of fall off. And I wish I had an answer for the fix to it other than just cover everyone. But,
Yeah. So we talk now as obstetrician gynecologists about the 4th trimester, which is the postpartum period. And we use that term to make it inclusive of the prior 3 trimesters. And if you're going to pick a trimester that's most important, it's actually the postpartum period. And that's where we do the least amount of public health programming. That's where sort of the mythic ideal of the good mom collides with the cold hard reality of caring for a newborn. That's where these insurance coverage shifts. That's where relapse happens. And that's where overdose and overdose death happens too. We have an epidemic of maternal mortality in the United States, and substance use is an increasing contributor to that. In the states that have looked at this, it's the leading or second leading cause of maternal death in the United States. And that's precisely when we kind of are pulling financial and et cetera support back from these women.
And this is something that's interesting because the states that never did expand Medicaid, this is the norm. I've worked in both expansion states and non-expansion states, and when I worked in a non-expansion state, the crisis came when they went to fill their prescription because the systems aren't in place to let you know that this is happening. So it feels very random and sudden when they show up. And they're like, please let me get this prescription, please let me get this prescription, and then no. And it's always on like a Friday, and then they show up in the emergency department on Saturday and Sunday, and opioid withdrawal and massive life crisis. Right. And that happens hundreds of times, well, I would say probably weekly, hundreds of times across the country, because that's just the way that these systems are set up, as a denial of a refill of a prescription. And then on the expansion states, it was the weirdest thing because I started in a non-expansion state, and our clinic was also in crisis on those days because then everybody would show up, and we finally, because we couldn't get a dashboard to know exactly who was going to run out and when and what our backups were, because some people would still continue based on a means-tested capability to keep it, and we never had that information. And so it just came down to when it got turned off, it got turned off. And so we had no way to know. And all of a sudden I started working in a state that had it covered, and I was having like a crisis moment, like, are they covered? Are they going to be doing this? And like, what are you talking about? They're actually just going to continue their care and get it done. And so it really was night and day for that family, that mother-baby dyad to be continued. And if anybody's had a small child at home at about 6 weeks in, that is stressful. And I will attest. Didn't know, right? Yeah, in case you have not aware of that. And adding on opioid withdrawal, now exodus from capability of treatment, and the possibility of now being in significant trouble because of that is really, I think, reaches a little, at least in the medical sense, a lot of ethics and morals.
Thank you very much. We have time for one last question. This question is from Wilson Compton, who is with the National Institute on Drug Abuse, and I guess this is really directed to the entire panel. What would you like to learn that would help you do a better job? That is, what research is needed?
Well, we need outcomes research. I mean, we need to see what the outcomes are. And in order to do that in addiction medicine, we have to actually land on what we call an outcome. Because right now, the only agreed upon outcome is retention and treatment. And that variability of that outcome is too much to actually have it be solidly stuck into a randomized controlled, placebo-controlled trial that is the backbone of modern medicine. And so the problem is, one, figuring out what are the outcomes that we are satisfied with, and we will call success, versus what are outcomes that are perfection and kind of ridiculous to ask for. And so that would be the biggest piece that I think would be really important, is to understand what are the set of outcomes that we should be striving for so that we can then set laws and policies toward those.
I would agree with that. I think, any research that should be done should be patient-centered with, engagement of the patients, particularly on those metrics as well. Something that I had echoed was a little bit of the prevention piece and research on the prevention piece, particularly looking at chronic pain management and better evidence for how we treat chronic pain to perhaps prevent some of the cases of opioid abuse.
I'd echo those two things. From the treatment box, we actually know how to take care of pregnant women, so it's not a research question, I think, as much as an implementation science question. But dialing it, earlier, I think things that we don't really understand or we haven't operationalized is, what is recovery? What are the social determinants of health? What are the modifiable life course risk factors? How can we reduce adverse childhood experiences? And is something that will have population benefit across the lifespans?
Thank you very much. Well, on behalf of IMI, let's give everybody a great hand. Thank you.
So I actually just want to step in real quick. Sorry about that, Craig. You're doing a great job, though. So we actually had a member from the audience was really interested in the conversation that took place about counseling under medication-assisted therapy. And she had found online, recognizing that this is being televised and wanting to have the panel respond to this, according to the SAMHSA website, under federal law, MAT patients must receive counseling, which could include different forms of behavioral therapy, and was hoping that the panelists could respond to that.
So that's been interpreted all over the map as far as what that means, and that could be delivered by the person who's writing the prescription as directed motivational interviewing. And so I think we have to be very careful when we start to mandate something that doesn't exist, because I worked in Michigan for a while, and in the Upper Peninsula and northern Michigan, in the very rural areas, it doesn't exist. And so what happens is they find the nearest warm body to deliver, quote, therapy. And when they do that, bad therapy is like wrong drug. I mean, you can really hurt someone, and suicidality can go up, and anxiety and depression and triggering and relapse can get worse with bad therapy. So mandating evidence-based therapy where available is the best we can do, because right now the behavioral science piece is lagging a little bit in this, because we know that cognitive behavioral therapy is helpful. We know that contingency management is helpful, and motivational enhancement therapy. But what happens when the door closes and that therapy starts? We don't have good science to know the fidelity with which that's delivered, which means that we hope it's done well, but we really don't know because it's hard to measure. And so I think the interpretation has been very loose, very specifically, because there are places that are truly haves and have-nots. And St. Louis is a large city, and I know some of the therapists in that area. It has one of the best universities in the country in that city. And when you do those things, you have access. But the minute that you move outside of St. Louis in a community that still doesn't have a PDMP, then you ultimately start to drop off rapidly in the capability to deliver something that's, quote, mandated.
Thank you. And that, I'm going to have to close off now. That really is another research opportunity as well, isn't it? Because we have here prescribers who also do counseling, and that's what's called whole person care. So again, thank you very much. Well, thank you again both to the panel and the audience. I thought this was a very enlightening and hopeful presentation and an interesting Q&A. There is ongoing innovation in the current Medicaid plans to address neonatal abstinence syndrome and keep the mother-child dyad intact. For our second and final panel of the day, we will learn more about babies with bright futures. It's a real pleasure for me to introduce our next three panelists, and we'll follow the same format used in the last presentation. First, Dr. Stephen Patrick, if you'd come join. Dr. Patrick is Assistant Professor of Pediatrics and Health Policy, Division of Neonatology at Vanderbilt University School of Medicine. Second, Dr. Paul Jarvis. Dr. Jarvis is the Chief Medical Officer and Senior Vice President for the Mission Impact March of Dimes. And thirdly, Dr. Stephen Subinyi, who's the Chief Medical Officer for Gateway Health. Thank you, gentlemen.
Good morning, everyone. I wanted to start with a patient story. A few weeks ago, I was asked to evaluate an infant in the newborn nursery. The infant was about 3 days old, and nurses were concerned that the infant had increasing signs of drug withdrawal. It was about midnight or so, and I met the 19-year-old mom at the bedside, and the infant was there having some signs of drug withdrawal, and the mom was tearful with feelings of guilt and about what was going on with her infant, just seeing the infant go through drug withdrawal. What I learned as I was evaluating that infant was that the mother was discharged earlier that day from the hospital. And of course, going home, the mom and the baby were separated because the mom didn't have a place to stay with the infant at that time. So we fortunately were starting a new pilot program where moms and babies could stay together. And when I examined the infant had some clinical signs of drug withdrawal, but consoled easily. In most hospitals, that infant would have been started on morphine. What we were able to do instead were to move mom and baby together to a different part of the hospital where they could stay together. And throughout that night, the infant's clinical signs of drug withdrawal got better, and ultimately, 3 or 4 days later, the infant was able to go home, never starting on any medication. It's important for multiple things, right? Engagement of families, getting out of the neonatal intensive care unit, but also just thinking about resource utilization. If I had started morphine on that infant that night, that's automatically another 10 days in the hospital as we go through a medication wean. I think patient-centered care can not only improve outcomes for families, but it can also be cost-saving. Doing the right thing can help in multiple different ways. You know, when I first became a neonatologist not that long ago, you're all looking at me like I'm 17, you know, neonatal abstinence syndrome was a relatively rare condition. And when I went into neonatology, it was, you know, to manage ventilators and small babies. And it was in the neonatal intensive care unit that I was introduced to this, to opioid use disorder. And hearing stories like of Emily, what families go through, it really began the journey for me and for our team. So I wanted to show just a little bit of data. So what is neonatal abstinence syndrome? So neonatal abstinence syndrome is an opioid withdrawal syndrome. There's a push to call it neonatal opioid withdrawal syndrome to be more specific. And I typically describe it as a colicky baby times 5. It's a baby that is more irritable, can have feeding difficulties, can have breathing problems, and you know, this can lead to dehydration. And less commonly, babies can also have seizures, although there's some controversy about that. These are some data from our research team on just the incidence of neonatal abstinence syndrome throughout the United States. On the y-axis here is rate per 1,000 hospital births, and on the x-axis is year. And so here, and I should say it's our NIDA-funded research. Thank you. Over the last decade or so, we've seen about a 5-fold increase in neonatal abstinence syndrome. And we could look at almost any opioid-related complication in the United States and see a similar trend. But by 2012, about 1 infant was born every 25 minutes with the syndrome nationwide, just showing the scope of the problem for both moms and babies. And this increase has been costly. This is the total hospital bill in the United States for neonatal abstinence syndrome. As you can see, for Medicaid, it's grown from around $560 million in 2009 to $1.2 billion in 2012. Overall, it's about $1.5 billion for the total hospital bill just for the birth hospitalization for neonatal abstinence syndrome. To put this into some context, that's more than the annual budget of the NICHD. Again, just highlighting the scope of the problem. You know, one of the things that just being in the neonatal intensive care unit, you know, I didn't want to put a bunch of slides here, but we know that care for neonatal abstinence syndrome is variable. The scenario that I put at the very beginning is somewhat rare. It's advancing by itself. It's trying to push me forward. So we know that care is variable, and you know, one of the things I wanted to talk about is, you know, as we have this opportunity here talking about what Medicaid's role is, I think it could be reframing the debate on how we think about this problem. What we've heard from previous speakers is that care is often siloed. We talk about the mom in one place, we talk about the baby, when what's good for mom is also good for baby. And how do we cut down some of these silos? Well, in 2008, Donald Berwick introduced the notion of the triple aim, comprising better health care for individuals by improving the experience of care, better health for populations, and reducing per capita costs. And I think this framework provides some guidance for us as we think about paths moving forward. It's really hard to argue that the status quo we've heard earlier today and for neonatal abstinence syndrome is acceptable. In many cases, care is fragmented, it lacks an evidence base, it's costly, and it leaves providers and families frustrated. So what could this look like for neonatal abstinence syndrome? I want to talk about first, you know, how this looks for individuals by applying the IOM's crossing the quality chasm. So care should be safe, using their guidelines on what good care, optimal care looks like. It should be safe, minimizing the risk from opioid administration as an example. It should be effective, ensuring that all care practices are evidence-based and eliminate practices that don't yield benefit. Care should be patient-centered, ensuring that when possible, the mother and the infant dyad stay together. Timely, ensuring that when patients need treatment, they get treatment without delay. Care should be efficient, reducing waste, including excess length of stay. And it should be equitable, ensuring that infants with neonatal abstinence syndrome receive the same exact kind of care that we give to every other infant. The next part, again, this is the 3 prongs of the triple aim, reducing per capita cost. Again, care for neonatal abstinence syndrome is pretty costly. And if we think about what that looks like, so overall about $1.5 billion nationally, it's about $93,000 per infant that are pharmacologically treated. Reducing per capita costs for neonatal abstinence syndrome could be utilized throughout other parts of the continuum, improving access to care for treatment, opioid agonist therapies for moms, as well as prevention. And then lastly, better care for populations, setting clear targets for what we want to see moving forward for infants with NAS and neonatal abstinence syndrome. I've got 1 minute left, so I want to use this for a little bit of a point of privilege. So first off, in your guide, we put the American Academy of Pediatrics policy statement on a public health approach to opioid use in pregnancy. You know, today is a day where we see the new health bill put out, and I just want to say this, that Medicaid works, and it works for my patients, it works for people in recovery as well. And I think we need to get that message out there again and again. 40% of enrollees in Medicaid are children, but they account for about 20% of expenditures. Even as we begin to look at some of the things that are put out, there's been some proposals about just increased funding, taking away money from Medicaid and putting it in an opioid treatment. As you've heard from this, we need coordinated care. The drop-offs that were described a bit ago, these are not good for mom and they're not good for babies. Medicaid works. Medicaid works, and it works for my patients, and I don't know what my patients, my children's hospital would do without it. So I think that's a message we need to continue to push forward. And I think, again, Medicaid can serve as an integrator and a coordinator for care for women with opioid use disorder and infants with neonatal abstinence syndrome. Thanks for your time.
So I think it's still good morning. I'm Paul Jarris from March of Dimes, and really March of Dimes is about healthy babies and healthy moms, and this is an issue very critical to us right now. You know, in so many ways in this country, we take the approach that when a woman becomes pregnant, sort of the starting line is the 2 stripes on a piece of paper or a lab test, and that's when we start our 9 months of care. And we absolutely know we cannot create healthy babies in 9 months. We can't rescue girls, adolescents, women who have not had access to care, lived in healthy environments and communities, and planned their pregnancies, rescue them from a whole lifetime in 9 months. And simply can't happen. And I think that's very pertinent, this whole look at the opioid episode that we're dealing with. I think I had a slide there, but I'll go over it quickly. So, you know, everyone has talked about this episode, how we've had about a 300% increase in neonatal abstinence during this period of time. And it's very important that this is a Medicaid meeting, because Medicaid pays for about 80% of that, most of it. And many people don't realize Medicaid pays for approximately half the babies in this country. And when you get to some of the poorer states down in the South, it may be 70%. So without Medicaid, we don't have prenatal care in much of this country. It's absolutely essential. But with regard to the opioid epidemic, neonatal abstinence syndrome is just one part of a much more complex system. And in fact, we are all complicit in the opioid epidemic in this country right now, whether that's the policymakers, whether that's the researchers, regulators, healthcare providers, insurers who will or will not cover therapy, the pharmaceuticals, the distributors, and certainly in healthcare, you know, the most common conduit here is through the healthcare system to these drugs. We're all complicit. There's an expression in quality improvement that every system is perfectly designed to get the results it gets. And our country is perfectly designed to create opioid misuse and disorder and neonatal abstinence syndrome. So we really have to recognize that this is a much bigger issue. You know, to me, it's somewhat shocking that a third of Medicaid-enrolled women of reproductive age and a quarter of privately insured women fill a prescription for opioids. Is pain really that prevalent? What is going on here? And are opioids the only way to treat it? Another research that I know you're working on. We need other non-opioid apps, but we've become a culture that relies upon these opioids, and it's true for pregnant women. And then opioid use. These were studies where the unidentified patients, around over 2.5% had urine tests that are positive just at delivery. And then a private practice, because often we stigmatize this and consider it a problem, even don't realize this is, of course, all socioeconomic groups. About 6.5% of the patients randomly came in selected, had positive urine. So it's so common, and it's why we need universal screening, because you can't look at somebody, we all know, and know whether they're taking opioids or not. So really, we think the universal screening is so important here. So prevention, and half the pregnancies in this country are unintended, which is pretty amazing when you think about it. We, again, have a system that is not designed for women to be able to choose when they become pregnant. I was visiting a NICU recently where one of the twin rooms was filled by a younger sibling and an older sibling in the NICU. And the nurse goes, well, this isn't uncommon. Well, that is absolutely a failure of our system, not to provide the mom with the tools. So it's very important that women have the tools to decide when to become pregnant. So if they have a chronic illness, including substance abuse disorder, their conditions can be controlled as much as possible. That's the same with hypertension, diabetes, any other condition like that. And of course, we want to space the time between pregnancies also to optimally have a pregnancy outcome. And we're seeing a third of the time pregnancies are way too short in this country. So it's so important that we give women those tools. Huge policy issue right now, but it's also a big practice issue in terms of, do women get access to highly reliable contraception? Again, I talked about universal OB screening. It's an ACOG recommendation, but I think one of the prior speakers talked about how infrequently it actually occurs. That's a systematic problem here. One of the reasons it doesn't occur is because docs don't want to know, because if they screen somebody and it's positive, then what are they supposed to do? I got 40 patients to see today. Again, the benefit of taking a more systematic approach, this nurse case manager approach is excellent. They can call a nurse, one phone call, problem solved. That's a doc that'll screen. But that's very ad hoc, as we're learning. It's not the way the system ties together itself. The avoidance of opioids in women in childbearing age, there is a black box warning, but I actually think there should be really good informed consent of women in childbearing age, so where they actually acknowledge that by being on this drug, if they become pregnant, it may affect their baby and the outcomes. I don't see many systems that do that. There are drugs like Accutane for acne, where it's mandated that a woman has to be co-prescribed a contraceptive with that drug. I really think that women should be offered that, should be co-prescription of a contraceptive, so that they can choose when to become pregnant if they're on a chronic opioid. It doesn't happen because people don't think about it. PDMPs, and Missouri is the only state that doesn't have one prescription drug monitoring system. Wouldn't it be nice if obstetricians' offices at the first visit actually check the prescription drug monitoring system to see if a woman had been prescribed opioids? I've never heard of it happening, but I think it should happen. The same thing at labor and delivery. Could they be checking in all the other states? Has a woman been prescribed prescription opioids? Many women who are on the chronic opioids have problems. This is not all street drugs, and even women who will use street drugs who are often driven into that because of their prescriptions will also use a prescription. So we would capture lots of women if we did this, but it isn't the standard of care. So again, the issue of what do you do if you find a positive screen? I'm a primary care doc, and there was nowhere I could send my patients, really. Maybe the ER, and then they just send them back to me. So we have to build the system around the doc. So again, the medical home is really important, but we have to build a system around it, like has happened as case management. But it shouldn't be one insurance plan at a time. It should be the fact in this country we should build a system where the default is that if a woman is identified, if she has a safe harbor, she can identify safely, and she is referred to a competent provider for treatment and receives that competent treatment. Recently read a paper where of the women who are in substance abuse, pregnant women in substance abuse treatment, only about a third of them are getting MAT. So there's really a problem there. Even when they get into treatment, are they getting the right treatments? So rather than having a system we do now, that everything runs in parallel. There are outpatient services that a woman may receive, medication therapy, the OB, and then a completely different system when they go in the hospital, which may not consider the MAT, they may not even know about it. And then the baby is born, they go to the pediatricians may not have access to the mom's chart or know why this baby's going bad. And then how does that all then connect back to back into the medication-assisted therapy, the primary care, the follow-up care, and the social work to wrap around the mom? We really don't have, I mean, it's good that we're building these individual systems, but it needs to be aligned around the woman through the whole course of her pregnancy. So these handoffs I think the case managers are there because the system doesn't work, and so they become the glue between all the parts of the system. But wouldn't it be nice if the system was lined up around the mom and she followed through? And all these handoffs were the natural handoffs. They're not an accident that happens. They're the routine. So basically, what I think is important here, we have to look at systemness. We can't look at just the patient. We can't just look at the provider. We can't just look at the hospital or just the social services or just the Medicaid. We need to come together in the states and do a project where that all is built as a seamless system for women. And I would actually point at Vermont as an example with their hub and spoke system where that happens extremely well. The first step in it happening extremely well was everybody in the state recognizing we have a problem, it is a disease, we want healthy babies, and so we're going to build a system to do it. That means getting over a lot of stigma. So March Time's doing, one of the interesting things we're doing now, just to tell you, is working with the CDC to build upon the birth defects registry, to actually be able to follow these babies along after birth through the years to see what kind of care they need over time, and so we can anticipate that and then proactively manage the patients to do that. So I'll stop there, but thanks very much.
Good afternoon. So I have a challenge. I think I have 6 minutes before noon, and I see the 94 dopamine levels on some of your foreheads. I was also advised many years ago by a mentor when I was teaching medical residents at Albany Medical College that you never stand between them and the pizza that's waiting for them after you give your talk. So I'm gonna kind of hop through a little more quickly. I'm gonna make some adjustments to what I'm saying. I've been with Gateway Health Plan for 3 months, so everything that I'm saying today is the work of my predecessor. You should know that. Mike Madden was the Chief Medical Officer, and he was working with the McGee Women's Hospital at UPMC and the Allegheny Health Network, and some of the work that I'll show you came from them. So I do want to say one thing that you've heard in different ways. Let's see if I can push the right button. And that is this phrase, if you're not part of the solution, you're part of the problem. You've all heard that. This is very, very true in the opioid crisis, which is a prime and pressing example of this phrase. It begs for broad collaboration and coordination, something that, as you all know, our healthcare system hasn't been particularly good at. To get things done requires leadership and elbow grease, and I guess I'm proud to say that Mike had both of those when he took this on a decade ago. And a while ago, you saw a graph that showed that the NAS epidemic and the opioid epidemic in women took off around 2006. And make sure I stay up there. Gateway actually began to recognize that this was happening in 2006 as we were looking at unexplained length of stay variations in hospitals for those who were in with neonatal abstinence syndrome, as well as opioid affected moms. And as we looked at that, we recognized also, which is pretty obvious, I think, to most people, that meant that clinical care probably wasn't standardized. And back then, standardization was less than it is today. And not surprising, because there were no treatment guidelines. Actually, treatment guidelines didn't really start coming out until a number of years later. So Mike pulled together experts in the Pittsburgh area where Gateway is headquartered, including obstetricians, neonatologists, NICU staff, and others, and said, what can we do about this? How can we approach this? And one of the things was, let's develop some guidelines for weaning infants. And that clinical work group did get together and publish some clinical guidelines, which were subsequently put onto a DVD along with Finnegan's scoring with the help of a local TV station. It was disseminated. There were 3 statewide conferences that Gateway hosted, and we continued to watch what was happening. Although we had hoped, or they had hoped back then, that these steps would make an an impact. We had little faith that it would. Guidelines, even national guidelines, often take 10, 15, 20 years to be adopted, and we didn't think we were going to see anything too quickly. So we asked ourselves, well, what else could we be doing? And so we identified that there were additional challenges. You've heard many of these today. One big one was there were no existing models to fund this care. And if you move neonatal abstinence syndrome to either fewer cases or get them out of the NICU, the first thing you have to face is that hospitals are going to lose money, and they're going to say, why would I want to do that? And I'm not commenting on their altruism or that sort of thing. It's a reality of business. And then also there were barriers, some regulatory, to paying for coordinated care, having multiple services in the same setting on the same day. So if you're going to coordinate, that begs that you find a way to pay for that. And then, very importantly, the teams of care that are necessary to provide the services in a coordinated fashion plainly didn't exist. Providers who could prescribe buprenorphine, obstetricians who wanted to provide care to addicted women, pharmacists with pregnancy expertise, and others with a focus on addicted mothers. And the social services weren't there and readily available for this group either. So we said, well, we've got to come up with something if we're going to make any impact at all. And so people rolled up their sleeves, and Mike got together with the head of DHS in Pennsylvania, a guy named David Kelly, and began to brainstorm and decided that they wanted to try to put together a pilot model with the help of DHS, with the help of all the physical and behavioral health MCOs. And while I said that very quickly, you should understand that is a monumental task. Pulling together an OB teaching hospital that belonged to UPMC, local behavioral health providers, and social supports and housing providers. The key in all of this was money, as you can well understand. And the health plans did, in fact, many of the health plans agree on a common shared savings model to help fund the first 2 years of this program to try to keep the providers whole while this was kicking off. So the hospital that was chosen, or stepped up to the plate, I should say, was Magee Women's Hospital, and they created the Pregnancy Recovery Center, which opened its doors in July of 2014, and you can see the numbers up there. And they provided a team approach which conforms with much of what you've heard today. And the center had some pretty good success, and not only with completion of the program at 50%, which is quite good, but also in terms of lower NAS treatment rates that were required compared to methadone and community buprenorphine programs. Only 39% of the newborns required medical treatment, and part of that was also related to using other modes of therapy to help the newborns. And the obstetric outcomes were better with a full-term average gestational age and lower rates of low birth weight babies. The other group that we worked with after we cut our teeth with Magee was with Allegheny Health Network and their Perinatal Hope program. And I won't go through all of this, spare you that, but it's a very similar program, highly coordinated, and they too are beginning to see some success with this program. And both Magee and the Allegheny program have now begun to develop additional programs in the Pittsburgh area, spreading this model out. So lastly, in the interest of time, again, I want to talk about the expansion of this model, because if it can't be expanded, it's not going to have the impact we'd like it to have. Much of this is based on a hub and spoke model that has already been described for you. The Pennsylvania Department of Human Services is pushing to have 20 similar programs across the state at any hospital with greater than 1,000 Medicaid births, and is working with the managed care organizations to make that happen. Gateway had developed a per member per month payment methodology to try and bundle things together so that we were actually paying for services that Medicaid in and of itself doesn't have on its fee schedule. And that has been well received as well. The state is also looking at what they're calling PACMAT, Pennsylvania Coordinated Medication Assisted Treatment, which is another hub and spoke type model where they will pay through a capitated rate for an addiction specialist physician and associated support structures in centers, and then work with primary care physicians who are out in rural areas to deliver the MAT. So I'll end with where I started, and that is that we all need to be part of the solution. In my office at Pittsburgh, I look over, I have a great office, I look over, for those who've been in Pittsburgh, the point is where the three rivers, Allegheny, Monongahela, and Ohio come together. It's a beautiful spot. And I look, and there are always loads and loads of people down there. Some of them are working, cabs are going by, or I should say Uber vehicles are going by. And I think to myself, if I had to, I know lots of those people have either a direct or an indirect problem with opioid epidemic. Could I pick those people out? Not a chance. They all look like just like you and me and everybody else. And it always reminds me that if we're not part of that solution, we're part of the problem. Thank you.
Well, just like the waters of the Allegheny, I'm appreciative that we've all come together and we are here at our final panel with an opportunity for some questions. So as a reminder, if you would just have your questions written down on index cards, Jennifer and others will pass them towards the front of the room. We had so much information to share. I know all the speakers didn't get to say everything they wanted to, so I think some of the questions will probably address part of the comments that they may have. This question is from Nick Dregario, who is the Senior Medical Director of OPMC. For you, it's what are the recognized long-term health effects and costs for infants born with NAS?
There we are. So there aren't great data in terms of looking at long-term costs. As far as long-term outcomes, that's also somewhat difficult to get a good sense of. There have been multiple studies that have been published. Some are older, mostly looking at heroin or methadone. A lot of those studies are confounded. It's also unclear what multiple exposures, including alcohol exposure, which we know is a co-occurring common substance to be used and is certainly associated with developmental delay. All that said, if you summarize the findings that are there, the themes that seem to come up are some visual problems like strabismus or lazy eye, some subtle issues with attention, and maybe some IQ points. But I would be hesitant to say anything other than we need more research in this area, because there isn't, as far as I'm aware, a single study that has looked in the modern day and contemporary epidemic that we've seen that has followed infants that have been exposed. And so we need research in this area, and I think we should be weary of drawing too many conclusions and remember what happened with the cocaine epidemic, where we had on the cover of Time magazine where it said a lost generation, and really what happened was a lot of stigma. So we should be careful. We should monitor. We should follow infants as they grow. We should provide the resources they need. Infants that have neonatal abstinence syndrome or opioid exposure should be referred to early intervention services, but we should be careful about the conclusions that we draw from the existing literature, I think.
Thank you. Other comments, gentlemen? Okay. Next is a question from Dr. Alonzo White, who is the Chief Medical Officer for Aetna Medicaid. How important is it to address the social determinants of health to treat NAS and the mom and babies in recovery?
Critical. I think that we know in so many treatments that, especially in the Medicaid population, where a mom may be working in a service industry where she has absolutely no time off, no sick time, no ability to go to a doctor's office on a regular basis. There may not be transportation there. And so to the extent possible, to bring the care to the mom in her home or a social worker, or in some programs, the most successful programs we have, for example, there's one in Puerto Rico where for one particular treatment for pregnant women at high risk, rather than making the mom come in every week to the doctor's office for a steroid injection, they actually will meet the mom at school, work, or home. And so, we may not be able to change the housing and transportation, but we absolutely need to take it into account and work around it to solve the mom's problems, rather than blaming the mom as being somehow, health illiterate or non-motivated. People are living the best they can.
I would just say, too, that when you have conversations with women in the neonatal intensive care unit or in the hospital, there are often layers of stories of trauma. So trauma-informed care is critical. Understanding that this is just one, Mishka had this nice diagram earlier. It's not as if someone gets pregnant and they say, I think I'm going to use an opioid now. It happens before then. And so understanding the complexity of that, of what's going on, really helps inform some of the solutions. And if we step back and think about this holistically as a community, a lot of the solutions are not picking the best drug in the hospital. That's really minor. It's about the structures of care that go on to really improve outcomes for families.
So prior to coming to Pittsburgh, or going to Pittsburgh, I guess we're not in Pittsburgh today, I was in Philadelphia, and I'm told that Pittsburgh is not too different. I imagine many of you experience this as well. On any given day, I cannot find 30% of our members. They may be in the streets, who knows where they are. And so the usual outreach kinds of things that we do, mailing, telephones, they don't work. We have to go out on the streets to find them. And the reason for that are basically mostly social determinants of health. And for many of the things we try to do with our members, or you all with patients, you can talk to somebody about cholesterol till you're blue in the face if they're hungry. Or you can talk to somebody about asthma all you want and taking your medications if they've got mold growing in their walls. Now layer on top of that what Dr. Waller said, and that is that these moms are facing literally a life and death decision every 4 hours. Social determinants of health become very important.
Thank you. The next question is there any movement toward a standardized protocol for NAS weans in the NICUs, which I think means that for babies who have neonatal abstinence syndrome, who are in the neonatal intensive care unit, is there a standardized approach or protocol to taper the opioids?
So we know that standardization works. So there was a large 200-center collaborative run through the Vermont-Oxford Network, which is a group of around 1,200 NICUs throughout the United States and some international NICUs as well. From that work, over a 3-year period, we took on issues like trauma-informed care, standardizing protocols, standardizing breastfeeding. It's not just about the medication wean, it's about all the other parts too. Centers that standardized more had decreases in length of stay and length of treatment. We know from the Ohio Collaborative that centers who have a standard wean had, at least in that collaborative, about half the length of stay. That said, there isn't one clear guideline, this is what you do, and that actually creates some of the variation that we see. SAMHSA, Michigan was on part of this as well. SAMHSA is releasing some guidelines, hopefully later this summer. I think they're going through clearance as we speak, that it can at least be some useful tools to try to standardize the care that we see throughout the community. And it's true what was said earlier, and from some of our work, we know that the biggest growth of infants with neonatal abstinence syndrome and opioid use disorder has been in rural settings with not a lot of resources often. So getting standardized protocols out to rural communities, I think, is pretty vital.
And I'd also say while we're waiting for the gold standard to standardize, just pick any good one and do it, because by standardizing the practice, no matter which you pick, you're going to do better than not.
Consistently, time and time again. Absolutely right.
The next question wants to know if any of the panelists know how many women who are on opioid treatment overdose, either fatal or non-fatal, during pregnancy.
Any of the prior panels? But what I can say is in looking at Texas's maternal mortality information, because we know the growth has been tremendous in their statistics, I recall looking at some of their information, and it was either the top 1 or 2 causes of maternal mortality was overdose. And what someone mentioned before, which was so important, is first of all, pregnant women should not be weaned. I think the science is pretty clear on that. But if they are cut off at 6 weeks, it's when you come out of treatment, you come out of corrections, or you go back to using after a period of not using, you're at a higher risk. So it is absolutely a setup for overdose and death if we treat women for 6 months and then kick them off. So.
And that data is actually in your C-drop and also on your flash drive and the reports from all that data.
Good.
Great. I think we have time for 2 more questions. This is from Dr. Susan Brown with Anthem, and part of the question has to do with sort of twofold. Should neonatologists be responsible for NAS? And when will policies be enforced and throughout the country to allow for rooming in with babies so that NICU admissions can be avoided unless the infant is otherwise unwell?
Well, I mean, as a neonatologist, yes. I think there's a couple of things. I don't think this is, if you walk around my NICU, you see ventilators, you see babies on heart-lung bypass, and you see a baby with neonatal abstinence syndrome, they look like they don't belong there because they are generally healthy babies. So in general, yes, I think they need to be outside of the NICU, and a general pediatrician is fine to care for and preferable in many ways because I think there's a culture difference. With that said, in some communities, it's not possible. There are many hospitals where the only pediatric services that are there are the NICU. And so figuring out how we figure out, in Vaughan and in some of the quality improvement culture, we talk about potentially better practices. Well, we know this works. It certainly works in our setting, but where there are constrained resources, how do we implement the same principles in ways that are different in different settings? So I think that's what I would say to that.
Thank you. Any other comments? The final question for the day actually starts with a compliment. Great to learn doctors and clinicians are knowledgeable about the opioid epidemic, specifically about innovative approaches to care for physical and behavioral health. The question is, and this I guess leads to the Bright Futures question, what are proposed tangible next steps so we are a part of the solution and not the problem?
There are a number of guidelines put out by a number of states. Washington State was one of the first to put it out. The CDC has actually put out some guidelines. So I would think, every individual can do something. Many states require mandatory CME. It's of marginal usefulness of my experience, but getting engaged and really looking at the opioid prescribing is the first step here. Also, some studies looking at standardized prescribing after surgeries, and because there's tremendous variation from 3 days to 30 days given to patients, when often 3 days will work, or sometimes ibuprofen will work. So I think really looking at it systematically and following these guidelines is what's going to get us where we need to as a very first step.
Just a couple of comments. One is to echo what you just said, and that is that we've had a terrible approach to pain management in this country. We have inadequate resources to manage pain, and our knee-jerk reaction is to manage pain with medication. And we haven't looked at other approaches, and whether it's physical pain or psychological pain, we need to do a lot of education and begin to think of other ways of doing things. The other thing that I just want to comment on is we have an opportunity here. I don't think that, well, maybe I shouldn't be absolute, but I don't think anyone really thinks that we shouldn't try to address this problem. And it gives us an opportunity to use this problem in a way to bring folks together, to develop novel ways that break the rules but address the problem. And we have a lot of regulations that are in the way. We have a lot of this is the way we do it in the way. We have a lot of misconceptions, whether it's about a health plan or whether it's about a provider or a patient. And we need to clear that stuff away and do some new thinking. And this is an opportunity to do that.
And one last comment.
And so I would say, as far as tangible next steps, one is to support Medicaid, because it's a pretty vital safety net for this population. And then thinking through the entire continuum, support throughout, applying public health principles, primary prevention, supporting things like unnecessary prescribing. If you look at the Green Journal, the OB Journal this month, they have a few things about excess prescribing post-C-section, highlighting actually some of the things that Emily said. Patients actually want less than we give them. That's important. Supporting prescription drug monitoring programs. Funding for prescription drug monitoring programs is often at risk, is not very much. Expansion of treatment. I think that's important. And then thinking about what we do for infants in the hospital, but also post-discharge to support families as they go home. We know that infants that have drug withdrawal are about twice as likely to be readmitted to the hospital compared to term infants. And I think in part it's because we don't provide a lot of support as they transition home.
Thank you so much. Please join me in thanking all of our panelists. We now have a changing of the guard, and it is my distinct pleasure to introduce to you Dr. Judy Chamberlain. She will provide some closing remarks for us. Dr. Chamberlain serves as the current chair of the Institute for Medicaid Innovation's National Advisory Board. She recently retired as a family physician in Maine. See that smile on her face? And as the Chief Medical Officer at Aetna Medicaid. In that role, her major area of focus was on Aetna's integrated care management program, and it focused on chronic conditions, perinatal care, and long-term care. She also helped to develop clinical programs for Medicaid members with a particular emphasis on the biopsychosocial approach to each member and to fully integrate physical and behavioral health for all members. Welcome, Judy.
Yeah, I like the retired part. I had to dig this suit out. So I really want to thank all of you for attending. I want to thank the sponsors, our speakers, our panel members, Aetna Medicaid in West Virginia for the video, and Emily, Caleb, and Caitlin for coming from Missouri. Should have brought my sister with you. There is no question that opiate use, overuse, misuse, abuse, and addiction have created an enormous and complex problem in our country with devastating personal and societal costs. In responding to this problem, if you remember nothing from today, please remember that opiate or any addiction is not a moral failing. It's not a sign of some weakness of character. It is a chronic and unrelenting illness. Like any other chronic illness or chronic condition, it requires that we screen for it, diagnose it, and offer treatment for it for as long as that treatment is needed. And it requires integrated systems of care to do that. We need to stop stigmatizing and treat. As a family physician who delivered babies for 29 of my 30 years in medicine, I saw this starting to come into my practice towards the end of my career in medicine. I've been out of clinical practice for 8 years now. So if I had a pregnant woman with diabetes and she took too much insulin and didn't eat the diet I had prescribed for her and came in a coma, I would not blame her. I would not punish her. I would not fire her from my practice. I would treat her acute problem and then sit down and work out with her how we could have that not happen again. But we expect the same woman who's pregnant with a substance use disorder to be perfect, never failing to keep an appointment, never failing to adhere to a strict treatment regimen, and then we create rules and laws that threaten her with loss of her child, threaten her with jail, and deny lifelong medication-assisted therapy when it's needed. All of that makes absolutely no sense to me clinically or socially. Our response to this crisis has to be better than stigmatizing, punishing, or jailing people addicted to opiates. Medication-assisted therapy has to be as widely available and affordable as any chronic illness treatment, and legislation should be aimed at providing funding for this treatment, as we all work to decrease new utilization of opiates and to avoid risking addiction for more Americans. Legislation also has to address how to continue medical coverage for women treated in pregnancy after their postpartum period. Expanding Medicaid is probably the only answer to that. It's the only answer that I see. Again, thank you for your attention and for your continued efforts to provide humane solutions for this crisis. Thank you.
Again, we want to thank everyone for your attendance today, and especially to all of our experts who shared their stories, their knowledge, and also presented some really innovative solutions for us all to take back as multiple stakeholders to address this issue across the United States. I want to thank everyone who joined us virtually online, and then those who will watch us archived. We appreciate your attendance and interest in this topic, so thank you again.